So, part 2 of, again, our book Metabolica, what the doctor orders. There are a few branches of modern medicine that have recognized both the problems and the importance of nutritional therapy. For instance, integrative and functional medicine, holistic medicine, and psychiatry. Their charge is to treat the upstream causes of disease versus the downstream of the symptoms. Many of these doctors and healthcare professionals eschew medications, rather opting to use food and supplementation as medicine. And this makes sense. The cellular pathways that lead to chronic disease are not druggable, but they are foodable. Unfortunately, such doctors are still few, far, and in between. They're kind of just starting to make their way now, and still people are like, oh, what is that? Some people know, some people don't, so it's like kind of 50-50. There are a few courageous practitioners who've spoken up, but most of them have been marginalized by the medical establishment. However, this new wave of physicians has some guiding lights and the data to make inroads into the medical debacle that we find ourselves in. Decades ago, the ability to dispense nutritional advice was claimed by dietitians. The field of modern dietetics was born out of two concepts, both of which turned out to be false. The first is the idea that a calorie is a calorie, which was espoused by the Atwater system developed by agriculturist Wilbur Atwater in 1916. His claim to fame was that he standardized how much heat energy, so how many kilocalories or kcal, 3 specific macronutrients would liberate when burned in a bomb kilometer, a device that measures heat release of organic substances. And he calculated the ratios, which computes the number of calories in a given food by its protein, which is that 4, carbs 4, and fat 9 content. As fat was the most calorie dense, Atwater thought it was the most egregious in terms of weight gain. Since then, dietitians have clung to the idea that patient's food plate can be calculated using this arithmetic. The problem is that our bodies are a bit more complicated than that. The Atwater equation neglected to account for the intestinal microbiome and its inherent metabolism of approximately 25 to 30% of everything you eat, as well as the role of fiber in altering that percentage. Since fiber doesn't contribute to any calories to your total, but alters the percentage of that total that you absorb, the number of calories you eat versus how many you metabolize are completely disparate. Nowhere is this more true than for nuts such as almonds, where the amount of calories absorbed is a full 30% less than those generated from a bomb kilometer. So what can you do to advocate for yourself? To make sure that you are making yourself foodable and trying to get off any type of medication that you're on, because we don't want that. You want to get the proper testing. So again, this is what the doctor orders. So there is this is going to be a laundry list of things, but read the blog for this week and you'll get a little bit more detail on it. But you want to get this list of testing to make sure that your doctor orders these. You want a lipid profile of LDL-C, HDL-C, triglycerides, homocysteine level, your alanine levels, and your aspartate, so ALT and ALS, or ALT and AST, uric acid, fasting insulin, fasting glucose, and hemoglobin A1C. Once you have those results, you'll take a look at your HDL. If it's over 60, it almost doesn't matter what the other fractions are. This is a sign of good cardiovascular health. If HDL is under 40 for men or under 50 for women, then your predisposition for heart disease is much higher. And then you'll look at your LDL cholesterol. If it's below 100, the small dense fraction can't be high enough to be harmful. If it's between 100 and 300, then you take a look at your triglyceride, your TG level. If the TG level is above 150, that's metabolic syndrome until proven otherwise. You need to assess diet and liver function. The liver enzyme ALT is easy to assess and reasonably sensitive and specific for measuring the degree of liver fat. If it's over 25, you definitely should investigate further. If the AST is elevated, you can assume your liver is either under acute, infectious, alcohol, or toxin-related assault. And if your ALT is elevated, then it's likely under chronic metabolic assault, so liver fat. If both are elevated, then you want to know whether there's been any liver damage. Uric acid is a byproduct of liver carbohydrate metabolism, especially when it metabolizes sugar. This prevents the mitochondria from metabolizing pyruvic acid to carbon dioxide, which forces the liver to turn excess energy into liver fat. Levels above 5.5 indicate mitochondrial dysfunction and insulin resistance. Signs of poor mitochondrial function are high uric acid and high homocysteine. Signs of liver fat are high ALT and high fasting insulin. Signs of poor peripheral clearance of fat are a high triglyceride and a low HDL. This pattern would argue for reducing your refined carbohydrates and sugar consumption, so processed food. Conversely, signs of poor liver clearance of fat include a high LDL without a concomitant high triglyceride, as well as a normal fasting insulin level. So you got to figure out where in lies the fat. You don't need that much liver fat for it to make a huge difference in your life, and it's not something that you can visibly see. So if you have any questions on part 2, what the doctor orders, feel free to leave a comment below.